Hello and welcome to Let's Talk, a series of award-winning podcasts produced and delivered by the Hazelden Betty Ford Foundation. Each podcast focuses on a topic related to addiction, from prevention and research to treatment, current events, trends, advocacy, and of course, recovery from a substance use disorder. I'm your host, William Moyers, and today our topic is personalized care in addiction medicine. Nobody is better positioned to talk about this than our guest, Dr. Marvin Seppala, the Chief Medical Officer of Hazelden Betty Ford. Marv?
Hi, William. Glad
Nice
to be here.
Yeah, good to have you back with us again. You and I go way back.
We do. Yeah, it's a treat. Always a treat to get together.
And yet you have a story that goes back even before your professional role at Hazelden.
I do. So I went to Hazelden as a 17-year-old high school dropout.
17.
Yeah, I got sober at 19 in Rochester, Minnesota. And a year later went off to college and then medical school back in Rochester at Mayo. And then during medical school realized I didn't want to be a cardiac surgeon. I'm going to go into addiction and work in addiction, and went and did a psychiatry residency and an addiction fellowship at the University of Minnesota.
Wow. How many years have you been in recovery?
44.
44 years. What's changed about treatment since the days when you were, finding recovery and all these decades later?
Yeah, I think the main changes have been the body of information available to make treatment decisions now is so much different. We actually know a lot about the neurobiology of addiction.
Yes.
And that hasn't yet resulted in the type of change we hope for, but it's starting to.
What do you mean by that?
There's certain medications that are helpful for addiction, but they still have kind of low response rates in general, like for alcohol use disorders. Mm-hmm. The medications for opioid use disorders are better. The kind of understanding how the brain works in a way that we could set up a psychotherapy that would be better for this individual versus that one, like personalized care,
Right.
Just for that individual, customized. We're not there yet at all. So someday we will be.
But hasn't treatment always been personalized? I mean, when you were seeking treatment and when I was seeking treatment at Hazelden in 1989, they were paying attention to me. Wasn't it personalized back then?
It was personalized based on the kind of main characteristics of the individual. So in general, treatment, like when I went, it was 4 weeks long.
That was it.
Whether you needed it or not.
28 days, right?
Yeah, it was 4 weeks for everybody.
Right.
And I was a 17-year-old high school dropout, and 4 weeks was not enough. I mean, I went out, and 5 days later I was using again, back in Stewartville, Minnesota, with no resources for an adolescent, except AA, which I didn't go to, so I didn't work to help myself. But so personalized care is really customized for the individual, tailored treatments, for that person, ideally based on kind of analytic predictors or biomarkers. So for medications, getting specific kind of a blood test that checks a couple biomarkers and tells you, William, this is the medicine you should be on versus this one, because this one you'll get side effects from, and this one will work way better. It's just right for you, compared to me, or I might have to take the opposite one for it to work right. And for behavioral interventions, they get a little bit ignored in the general medical description of personalized care. But for us, working in addiction, it's such a complex illness, we can't limit our treatments to the biologic. It can't just be about, finding a genetic biomarker for this particular medication. We have to have other means of choosing which psychotherapy to use and which kinds of treatments to use. And, would this be the better course for this individual with PTSD? The medicine, the therapy, all of that. And we aren't there, but we'll get there.
What's going to get us there, though, Mar? How do we personalize addiction treatment for each person?
Right now there's things we can do. Project Match, an old research study about psychotherapies for alcohol use disorders, compared 12-step facilitation therapies, so preparing people to go to 12-step meetings, to cognitive behavioral therapy, to motivational enhancement therapy. And as it turns out, for people whose social circumstances support ongoing alcohol use, they're better off with 12-step facilitation than the other two. But for an angry person, the motivational tools work better. So that's actually a personalization. You can pick the psychotherapy based on the patient characteristics, and that is available right now. You could make those decisions based on that information. And we're actually doing research in partnership with Mayo, looking to determine these genetic and metabolic biomarkers. So just a simple blood test of things that are normally floating around in our blood that will determine who responds to this medicine at camprosate for alcohol use disorders. And this is going to take 4 or 5 years to figure out, because it just takes a long time. Once we have this figured out, we'll be able to tell someone, you should take this medicine, while this other person should not. In fact, it only works for about 10% of alcoholics, so it's always been thought that it was a genetic subtype.
Yeah.
So we're going to try and define how to tell and who should take it and who shouldn't.
But Marv, even in our system of care at Hazel and Betty Ford, with facilities all over the country, residential facilities, IOP, outpatient, day treatment, how can we reasonably expect to personalize care when we're treating thousands of people?
Once we get it nailed down, should be able to just, like in the example of the medication, a simple blood test on admission makes that decision. So very easy. We're going to be taking people's blood anyway for other purposes. The information we gather on admission can be used because it describes all kinds of patient characteristics. And we're also doing another project with the University of Minnesota using data analytics or artificial intelligence. We're giving this group at the university hundreds of thousands of old patient charts. They're de-identified, can't tell who they are, but it describes all these characteristics, and then we have the follow-up data for how they did over the first year of sobriety. And so what we're going to do is develop, we don't know how many, let's say 6 or 7 different patient risk profiles, almost like cancer staging, Cancer stage 1, it's there, but it's not life-threatening. 5 is really serious and life-threatening. It'll be the same kind of thing, that for people that might be likely to overdose, we should have a profile and then treatment planning associated with it. But we can do that based on information they give us with their first phone call before they even come in the door. So that it doesn't even take time, really. It's just part of our system electronically, and we just plug and play, basically, for that individual.
What is the role that technology plays in all this?
A really major role. So both of those studies, that medication study we're partnering with Mayo on, requires artificial intelligence to really determine what those biomarkers are, because it's just too complex otherwise for the human mind to get a handle on. And it can identify those things that one wouldn't be able to even notice. So that's one area. The electronic health record then maintains all this information right from the first phone call, so that we can use those characteristics to determine who fits into those risk profiles from that project at the University of Minnesota. And it should automatically populate that person's chart with a treatment plan specific to that risk. So let's say their major risk is leaving treatment early and relapsing. If we can reduce the number of people that leave treatment early and relapse based on a specific treatment plan that's for that kind of profile, that's a big deal. And the electronic aspect of it just makes it quick and easy for our counselors and our docs.
And so this whole focus on innovation, this focus on personalized care and addiction medicine, obviously there's 2 goals there. One of them is to do a better job treating the patient, but the second one is also to improve the prospects of a better outcome.
Sure is. Yeah, always. In the back of my mind, it's always about better outcomes. And, and in a way, it should be in the back of all of our minds in addiction treatment, that how can we get better outcomes? And to me, personalizing care is one way of really doing that. We've always talked about, in addiction, individualized care.
Right.
But it was based on, this person has, a cocaine use disorder and PTSD, so we're going to get them a counselor for their PTSD, and we'll treat their cocaine use disorder, but we'll do it the same way we treat other addictions anyway, really. I mean, there's certain, if they're from New York, we'll set them up to see somebody when they get back to New York. So they're basically kind of major aspects of the individual's character that we can easily identify. What we want to get to is, if possible, underlying, kind of biologic information that could drive our decision making, or these predictors of response to treatments, that we're doing exactly what would be right for that person. And we'll never get exact. We should be able to get close, but it'll be much more specific, much more tailored to that individual.
But Marv, I can hear some people out there who saying, why are you getting so medical or so complicated or so technical on us? All you got to do is hang those 12 steps up on the wall and let them follow that. What's your answer to that?
Even within 12-step programs, I would say that people have the luxury of choice. They get to choose how they work those steps. They're suggested steps. They're not required. They're not mandatory. And so it becomes individualized, and they get to choose their sponsors. They get to choose what meetings they go to. They get to choose who they surround themselves with and what else they read about those steps and how to work them, and then figure out for themselves over time what that means. And even spirituality is left up for the individual to define for themselves in a way that works for them. So I see that as really personalized in a way that we can learn from, actually. It's kind of funny that way.
Well, Marv, we really appreciate your being with us today to talk about personalized care in addiction medicine and talk about the importance of a good outcome. And I think it's always remarkable when you and I get to sit down together on these Let's Talk podcasts to realize that you and I were once people who were baffled by our use of substances.
We're lucky to be alive and doing this.
All these decades later,
Yep.
here we are at the Betty Ford Center, talking about things that used to baffle us.
That's right.
The disease. I really appreciate you being with us today.
Oh, thanks, William. I'm glad to be here.
Dr. Marvin Seppala, the Chief Medical Officer of the Hazelden Betty Ford Foundation. And this has been another podcast of the Let's Talk podcast series. We hope you've enjoyed our topic for today, and ask that you spread the word and let your friends and fellow travelers, your colleagues and your families, let everybody know that these Let's Talk podcasts are alive and well and current in our new year here at the Hazelden Betty Ford Foundation, and we hope that you'll tune in again. Thank you very much.